All right, let's talk about what happens if we have a particular symptomology of elevated or expansive mood. Now, this decision map comes from the DSM 5 differential diagnosis. I wanted to go through it with you and make some commentary of it. Typically, this is what's going to happen is we are going to be more so presented with particular symptoms, and then we develop the diagnosis. So it's good to be able to do both case scenarios as well as looking at different symptomology. So let's get started here. I will go through kind of very quickly just so that we can get an idea of how to break down and follow these decision maps. So first of all, if we have elevated or expansive mood, so when we're talking elevated or expansive mood, we're talking about those who are kind of uncharacteristically behaving in ways that are very kind of similar to grandiosity, kind of an inflated sense of self. They're overly happy, overly charismatic, usually talking, kind of pressured or quickly. They usually have a higher sense of self or self importance for other people or for themselves above other people. And sometimes it involves impulsivity. So they begin to kind of spend more. There's this elation of, going out and spending and more risk-taking behaviors. So this elevated and expansive mood, one of the very first things that you need to ask yourself then as far as symptomology is there a substance involved? So as we know, that's the first main question of a differential diagnosis. Is there a substance? If we say yes, that there is a substance, then we go on to kind of this next phase of the map where we're asking ourselves, well, if it is to a substance, are the symptoms of the elevated or expansive mood the predominant issue, and do they warrant clinical attention? So if we're finding that, yes, there's a substance and the main issue is this elated mood, expansive mood, charismatic, uncharacteristic, like overly friendly, self-importance, grandiosity, then we would actually, at that point, if it is the, predominant clinical presentation, and we say yes to that, then we are actually then looking at a diagnosis belonging to a substance or medication-induced bipolar disorder. Again, this having to do with the predominant issue being expansive mood or elevated mood due to a substance, and that it needs clinical attention. If the answer is no, well, let me back up just a little bit. So substances or medication that may induce kind of bipolar, this elevated expansive mood, that certainly could be some form of a stimulant that could do it. You may have an undiagnosed bipolar disorder who either a physician or prescriber may have prescribed them some sort of maybe antidepressant, and because it was undiagnosed bipolar, all of a sudden that SSRI or whatever the antidepressant was kind of kicked them into a manic phase, and there all of a sudden there was an elevated mood, expansive mood. So it really kind of induced a bipolar episode there. So that would be an example. Let's say, though, for the sake of this map, that we say that it was due to a substance. However, the expansive elevated mood was not the predominant issue and didn't warrant clinical attention. If we answer no to that statement, we actually go down here and it's much more of a generic substance intoxication. So we're just, their behaviors change, they're maybe showing signs of some sort of elevated mood, but it's not the predominant issue. It's not sufficient to warrant clinical attention. There's just been some sort of change in them because of a substance. Usually that would just then be a substance intoxication or a substance withdrawal with adverse effects. So let's move on down here. Let's say that it's not due to a substance. Let's go ahead and let's say we answered no to that, to a substance. But then we get down to a physical, kind of a general medical condition. So let's look at that symptomology. And let's say that we answer potentially yes, that there is a possible general medical condition occurring The next symptomology that we're looking at is there some sort of cognitive decline? So if we're looking at cognitive attention, executive functioning, memory, language, perception, if we are finding that that there's some sort of cognitive issue going on as a result of some sort of general medical condition, then we would move over here and the diagnosis actually changes to more of a major or mild neurocognitive disorder rather than a bipolar disorder. The key issue being the changes in cognitive functioning, memory, perception, executive functioning. That's something neurocognitive going on. Certainly that merits a definite referral to a physician, emergency room, a neurologist for that type of diagnosis. However, if we say that there's some sort of medical condition occurring, however, it has really nothing to do with significant changes in the cognitive domain, and we answer no, then it could be a bipolar related due to another medical condition. Now, this is pretty curious and pretty specific. There's some things such as a cardiovascular or a cerebral vascular accident that could potentially be along the lines of a condition that mimics bipolar related symptoms. It's been debated whether hyperthyroidism could possibly, because of the increase in the thyroid, could possibly create kind of this anxious distress and potentially more manic-like or more energy-like behaviors. Not necessarily substantiated highly or highly correlated, however, it's one thing out there. There are others disorders that could be more of dopamine related, such as Parkinson's or anything like that, Huntington's, that may also kind of cue us into maybe bipolar like symptoms due to a medical condition. So here we have, we've kind of discussed substances and the map for that. We've looked at general medical conditions. Let's move on now towards more classical behavior now that we've kind of ruled out substances and general medical condition and seen the map there. All right, let's get started here with this portion. We're moving down. We've ruled out substances. We've ruled out general medical conditions. Let's say then at this point, for the sake of argument, that we're now looking that the criteria for a manic episode has been met, which if we've studied up, we're looking at least a week of elevated or expansive mood, which is our original symptoms. And that's accompanied by an increased activity and increased activity or energy, and then 3 other characteristics that would cause severe or marked impairment. So let's say that we've met that. We've had a week of elevated mood, increased activity, and 3 other symptoms causing marked impairment. If we say yes to that, then we know that because it's reached at least a week and it's increased activity and 3 other symptoms causing marked impairment, that we're actually looking at a manic episode. So we're going to actually follow this map down to this area here. Let's say then, for some reason, they haven't met that 1 week mark. However, we're looking at potentially a hypomanic episode, so at least 4 days worth of elevated or expansive mood. Again, that's our original symptomology with increased activity. And this is the switch, or here's the differential diagnosis portion, is that it's not severe enough to cause marked impairment. So this person's still functioning, however, they're still showing elevated expansive mood, talkativeness, some grandiosity, some creativity, some impulsivity, but not marked impairment. If they haven't met it for the manic, but they've met 4 days of the elevated mood and the energy and the activity, then we're going to move over here to potentially a hypomanic episode. And we're going to kind of continue down this path here. So then, once we've either decided whether or not it's going to be a manic episode, if they met that criteria, or a hypomanic episode, if they met that criteria, and it's not causing marked impairment, we have to then decide at this point, whether or not they've had a present, whether or not this green pathway from the manic episode, whether it's a present or whether they've had a past manic episode. And this is the big decision then, is if they have had a previous or a current manic episode, they're meeting that, and we answer yes, then we ask ourselves, is there a history of delusions or hallucinations? This is where things get a little bit tricky then. If there's a history, if we say no, let's just continue on to the right. If they've had a present or past manic episode, but the history of delusions or hallucinations is a no, then we're simply, it would be most likely a diagnosis of bipolar 1 disorder, because there's been no history of delusions or hallucinations, and they're either currently having a manic episode or in the past. And that would make sense. If in fact, though, they have a history of delusions or hallucinations, and we say yes to that, we then follow the map of asking, well, did these psychotic symptoms occur exclusively during a manic or major depressive episode? So that's the key phrase then, is did it occur exclusively during a manic or major depressive episode? If that's the case, if it occurred exclusively, then we move over here and it would be a bipolar 1 disorder with psychotic features, meaning that, these delusions and hallucinations occurred specifically during that episodes. However, if that wasn't the case, if it didn't occur exactly within that manic or major depressive episode, we're actually looking then more so at a schizophrenia spectrum disorder. And then we should follow the decision-making tree or decision-making map for possible differential diagnosis. As we know, this could range in the area of possibly schizoaffective disorder or, some sort of schizophrenia, but schizoaffective would probably be the most appropriate, given the fact that if a person has had a history of delusions or hallucinations and it didn't occur exclusively during a mood episode, and these delusions or hallucinations continued, we are looking more along the lines of a schizoaffective disorder. All right, so that kind of brings us down through this portion of the map. Let's continue on to the final portion. Okay, so now we're coming down from above. If they hadn't had a present or previous manic episode, the next question we ask ourselves is, have they had a previous or current hypomanic episode? So this follows from the map above. If they hadn't met the criteria for a manic episode, then we would follow the pathway for a hypomanic episode. And let's say that, yes, that they have a present or past hypomanic episode. We ask ourselves the same question as we did before in the previous little map, which is, do they have a history of delusions or hallucinations? If the answer is no, then we're moving towards a diagnosis of bipolar 2. There's been no evidence of delusions, hallucinations. They had or currently have a hypomanic episode, and at least one, if we remember, they have to have at least one depressive episode to accompany the hypomanic episode. So in that case, it would be a bipolar 2 disorder. Now, let's say that we answer that yes, they've had a history of delusions or hallucinations. A similar process occurs then, in that you ask yourself, did these delusions and hallucinations occur exclusively during a major depressive episode? And if that's the case, or I would say in this case, typically it doesn't rise to the occasion. If having a hypomanic episode with delusions or hallucinations, that usually doesn't quite match up because they haven't reached that marked stage of impairment. Typically with a hypomanic episode, they're not reaching that stage of hallucinations or delusions. So in this case, though, if they've had psychotic symptoms during a major depressive disorder exclusively, then we're looking at a bipolar 2 disorder with psychotic features. So if we answer yes to history of delusions and it's exclusive to a major depressive episode, then we're looking at bipolar 2 with psychotic symptoms. If we say no, if these delusions or hallucinations occurred separate or outside of a major depressive disorder, a mood disorder, then we get back to discussing whether or not it's some form of, such as a schizoaffective disorder. There's some sort of mood disorder going on. However, it's not exclusive just to, the psychotic symptoms aren't exclusive to the major depressive episode, which falls out of the active symptoms, which, as we know, we follow the decision-making tree for and map for delusions and hallucinations, which will likely land us somewhere in the ballpark of schizoaffective. Now let's continue down. Let's say that they haven't met the manic episode, they haven't met a hypomanic episode, so now we're really cruising down the pathway then of discussing whether or not they've had 2 years of hypomanic symptoms and periods of depressed mood. So they haven't met the criteria for hypomania, they haven't met the criteria for a major depressive episode. If that's the case, then we probably have learned by now that if they haven't met those in 2 years, they've come close to depression, come close to hypomania, but haven't quite reached it after 2 years, then that would be a pretty classic cyclothymic disorder diagnosis. If that wasn't the case, it's interesting that the DSM, this decision-making tree, it asks you whether or not the elevated or expansive mood was due to gambling. So in the DSM map, in their mind, if you're experiencing some sort of elevated or euphoric mood and it's not mania, hypomania, some sort of delusion, hallucination, then the next thing, kind of interestingly enough, is it gambling? So you ask yourself, well, is it combined? Is it an episode of gambling? You then ask yourself as a diagnostic or differential question, is it leading to clinically significant impairment? So is it persistent and problematic gambling behavior? That's what needs to be underlined here in red. Persistent and problematic gambling leading to clinically significant impairment and distress. Okay. If it is, there we go. If it is, then we're going to follow the pathway over to that indeed we're talking about a gambling disorder. And the funny thing is they didn't, this map, this actually should be a yes right here. So if indeed it is causing clinically significant impairment, and it's persistent and problematic, then it's a gambling disorder. If not, if they're elevated euphoric mood, it's confined to periods of gambling. However, it's not persistent and problematic, and it's not leading to clinically significant distress, then we actually are going to follow the pathway down here to no, which is normal gambling behavior. And finally, here we go, the last thing. If it's not due to gambling, and it's clinically significant manic or hypomanic symptoms that are not covered above from a physiological or biological dysfunction in the individual, if there is clinically significant manic or hypomanic, but it's not covered in the areas above, then we actually move over here. Or if it is, it's actually a bipolar NOS or bipolar unspecified. So, you're essentially saying that there's enough symptoms there, but it's not quite falling into any of these categories, then it's really an other specified or unspecified bipolar. You just can't quite find the right category. And there we go. That would lead us down to an unspecified diagnosis. And then we follow the chart down. If that's a no, then we continue on to the final portion, which at this point, the DSM considers this what we would just normally call this as normal elevated mood. So maybe you just got engaged, maybe you just won the lottery, the birth of a first child, something to that effect. You had an amazing, birthday party surprise. You had elevated mood. You met your famous Hollywood star, whatever the case may be. So at the very end of this, if there wasn't significant symptoms to merit a hypomanic or manic episode, you were just kind of elevated mood and expansive mood, talkative, a little bit more excited than normal, that would be a normal elevated mood. You're human. So there you go. That is the decision making a map for elevated or expansive mood as the primary symptomology.